So let's start the session. This is a question and answer session, and this is not a training course right now what we are conducting, but a question and answer session for our registered candidates who are registered for our different server based courses. So this is not a training course right now, but a question and answer session for our ongoing registered candidates. Now we have got some questions today. First question is from Dr. Anusha Priya. Sir, please explain which plane we can visualize to see the cleft lip. Next, from Dr. Kalpana, how to measure the Doppler flow of a perifollicular, the perifollicular flow she wants to know, endometrial flow, how to calculate it on Doppler. Then Dr. Niharika is posting the question that she is having regular cases of post-oocyte pickups are there in the, her clinic or the hospital where she is working, and she is always getting the ovarian volume on the higher side. So you can yourself go through the questions. So these are the multiple questions. I am having one more page of the questions. So we will discuss these questions in detail today. So starting the session now. Now, taking the first question, I am having the printout of these questions over here. Now, the first question from Dr. Anusha is, sir, explain the planes for visualization of cleft plate. Now, see, the cleft plate and this palate as well as the lip are seen when the section is cutting not like this, not like this. This is the transverse section, you know. Now, if the section is cutting through my face, then only these lips will be visualized. So this has to be a coronal section. In coronal section only, we can see the cleft lip as well as palate. We have to move a bit towards the inner side. So the point is we can get the clefts in the coronal sections only. How to go to the coronal section, that is the part and parcel of our course. Okay, now there are some techniques how to see for these, how to go to the coronal section. For that, we are having about a 40 minutes class in detailed fetal ultrasound. So the coronal section is the appropriate section to see the face as well as the cleft. Now, next question is from the same doctor, Dr. Anusha, which reads, is peak systolic velocity of ductus venosus is different if we scan in first and in third trimester? Now I am elaborating the question for others. The question is, if we scan a ductus venosus, as already discussed with those candidates who have completed or undergoing the color Doppler course, that the peak systolic, peak systolic velocity of ductus venosus is very high. Because I need to see whether I am in a hepatic vein or in ductus venosus. Now the question from Dr. Anusha is that, is it always high? By always, she means in first trimester as well as in third trimester. Yes, it is always high, be it first trimester, be it third trimester. There can be a big difference. From first to third trimester, it increases, but it is always and always high, be it first trimester, be it second, be it third trimester. And this high peak systolic velocity, the velocity is very important because I have to differentiate at times whether I am dealing with a hepatic vein flow or the ductus venosus. So the answer is yes, it is always high. Be it first or be it the third trimester. That was the question from Dr. Anusha Priya. Let me project the questions also. So the next question from Dr. Kalpana. Next, Dr. Kalpana is posting the question. Now I'm showing the question also. Yeah, got it. Now, these two questions from Dr. Anusha we have discussed. Now the next question is how to measure Doppler flow of perifollicular flow, endometrial flow. Please explain. These are the copy pasted questions. What I mean by copy pasted questions, as we got the question, we copied and we pasted over here. So the language is original as we got, we just pasted on to this PPT. Now, the question from Dr. Kalpana is how to measure the Doppler flow. Like we are measuring any flow. What is wrong with this perifollicular or endometrial flow? Like we are measuring any flow, we are measuring the flows of this follicular flow or any flow. Why you are confusing? Now, there is one more question. There is one more question which is also related to this. That is why I am taking this. Now see, whenever you see a flow, what is this? This is the baseline. You will see the baseline like this. Then you will see the systole like going this. Then again like going this. And the third and so on. Now, you know that this is systole and this is diastole. This is the baseline. Those who are already done with the color Doppler or undergoing the color Doppler will understand better. Now, how to measure? First, you have to trace it. Now, how to trace? Like you are measuring, you are tracing also. Now, take the cursor over here. This is first wave. This is second, this is third, and so on. Now, trace it like you are measuring. Trace it. I mean, I am tracing now the diastole. This is the diastole. Then go up and follow the wave. But don't stop. Go with second D. That means the second diastole. Don't stop. Go up. And up to here. Now, why I am saying up to here? Because up to here, what I am doing, I am now tracing the two waves. Now see, two waves. One diastole over here, one systole over here. One diastole over here, one systole over here. And I am freezing. I am setting rather here. So, I am actually tracing the two complete waves. And on pressing on setting over here, the pop-up will appear. What the pop-up will appear? The pop-up will appear that I am having now the resistive index, the PI, RI, and everything will pop up over here immediately. So the point is that I have to trace at least two waves. So there is some issue. The issue is not from our side. Now, somebody is sharing the screen. Please don't do these types of things. Don't share your screen. Don't draw anything on the screen. So the point here is that I have to trace two waves, complete two waves. So, next question. Okay, let me elaborate this because there is a question also by another doctor, how to measure RI. When you are tracing this, now see, when you are starting from here and you are ending over here, I mean, you are setting over here a resistive index. You don't have to calculate the resistive index. Machine will calculate the resistive index for you. But you have to trace the two waves. When you will be tracing the two waves and setting over here, The RI will pop up this much, PI will come up this much, maybe S by D ratio, and maybe other things will come up. The point here is that you don't need to calculate the resistive index. You don't need to calculate the PI. You have to trace the two waves, but your tracing should be correct. By correct, I mean you have to trace at least two waves. And in two waves, there should be two diastoles, like over here, one diastole over here, one diastole here, one systole over here, one systole. So two complete waves you have to trace. A machine will come up with resistive index is this much, PI this much, S by D ratio, and other things this much. So, next question. Next question from Dr. Niharika. Dr. Niharika is posting question. I am reading over here. I am regularly doing follicular scan and post oocyte pickup scans. I want to know in Mindray machine how to check the volume of the ovaries. Please kindly help me in this query as the overall volume comes too much. So I must be doing these calculations wrong somewhere. This is the question. Dr. Niharika. Now I am elaborating the question. I am simplifying the question. Rather, Dr. Niharika is always getting, not always, usually getting a big ovary when she is calculating the volume. She is getting an oversized ovary. Actually, the ovary is not oversized. The ovary looks normal, but the volume, whatever she is expecting, is more than what she is expecting. For example, she is expecting a 5 cc or a 6 cc, all of a sudden it comes 12, 14 cc, maybe 18 cc. So her expected normal ovary is not coming up when it comes when she is making the volume calculations. Now she wants to know where and what she is doing wrong. Now see, you have to keep, there is a class of volume calculation, how to calculate an accurate volume. For volume, you have to give 3 measurements. And 3 measurements are not possible in one plane. I am not right now taking the volume calculations because that is already a part and parcel of the course. Please go to the volume calculations. What can be wrong is that when you have to give 3, you have to give 3 measurements when you are taking the volumes. But maybe your section where you are taking the measurement is wrong. Now, let me take in brief. For volume, what we have to take? We have to take 3 measurements. One is the anterior posterior, another is the width, and one is the depth. Now for volume, I have to take anterior posterior diameter. This anterior posterior diameter can be taken in longitudinal or transverse section. This width cannot be taken in transverse section, and this depth can be taken either in transverse or in longitudinal section. But the basic important point is that when you have to take the dual frame is not to save the paper. When you are printing, it's not for to save the paper, but to take these volumes. You have to put on one frame, in one frame, transverse section, and in another, the longitudinal section. Like the ovary over here will be more round or oval in transverse section, whereas in longitudinal section, it will be a big elongated. Now, from here to here, you have to take the length like this, width like this, and the depth like this. Then only whatever volume will come will be the accurate volume of that ovary or any other thing what you are calculating right now. So the basic important point is that you have to keep the dual image. Number one. Number two is that don't give the wrong measurement to machine. By wrong measurement means maybe that you are taking it, now see, from here to here, maybe from here to here, maybe from here to here. No, you have to give one measurement in length, one in width, one in depth. Then only whatever machine will give you will be the accurate, or otherwise it will be maybe more than the original or less than the original. By original, I mean the actual. So I will recommend you to go to the volume class, that is in physics and machine settings, the volume class, where there is a detailed class how to calculate the volume. What I am thinking, Dr. Kalpana probably, no? Dr. Niharika, you are not giving the accurate volume because your section is not accurate over there. You have to keep dual image, one in transverse and one should be in a longitudinal section. Then take the measurements. Machine is born blind. Machine is following your commands. Machine is taking as if you have taken the right measurement. Actually, you have given the wrong measurement. That's why it comes more, or sometimes it will be less. So give 3 measurements in 2 sections. That was Dr. Niharika's question. Now Dr. Papu. Dr. Papu is posting, what is MCA, umbilical artery PI ratio? What is its use? Second part is how we diagnose fetal anemia. Fetal anemia we have probably discussed last time also. In fetal anemia, let me take the fetal anemia in 2-3 lines. In fetal anemia, the peak systolic velocity will be more than normal. Now, how much is normal? For that, we are having charts over there that we have discussed. Now, if the peak systolic velocity, now where is the peak systolic velocity? Now, whenever you see a wave, now here you don't have to trace. When you have to see the peak systolic velocity, you don't need to trace over here. You have to see to this peak. This is the systolic peak. Then in machine, there's a scale over here. This is baseline, the 0 will be here. So it will be 1, 2, 3, 4, anything written, something written over here. You have to see where this peak is, and this peak corresponding to how much the machine will show you over here. If machine is showing you, for example, the 50 over here, if machine is showing you 50 over here, it means that the peak systolic velocity is 50. Very simple. So now if this peak systolic velocity is more than normal in middle cerebral artery, then we are dealing with then we may be dealing with a fetal anemia. Second question from Dr. Papu is, if BV peak systolic velocity is up to 50, am I at hepatic vein? This is again another form of the previous question where we discussed the DV velocity. The point here is that Dr. Papu wants to know, am I in ductus venosus or hepatic vein if they diastole, if their peak systolic velocity, I mean the velocity of the ductus venosus is about a 50. If it is less than 50, then yes, you have to think that you may be in a ductus, in a hepatic vein. But not only the peak systolic velocity, but the flow also, if reversed, then you are in the hepatic vein. Those who I am repeating for the third time now, those who have not even touched their this Doppler will not understand me much. So not only the peak systolic velocity of the ductus venosus you have to see, you have to see whether there is any negative, I mean the reversal flow, because in hepatic vein there is a reversal component. So a low peak systolic velocity with a reversal component means that I am not in a ductus venosus, but maybe in a hepatic way. Now, third question, or maybe fourth question from Dr. Papu is how to diagnose fetal hernia during level 2nd. Now, see the fetal hernia, how to diagnose the herniation in the level 2nd scan. I am not seeing the hernia in a fetus. I am not seeing a hernia in the fetus. Now, how to make a diagnosis of a diaphragmatic hernia? A diaphragmatic hernia, I am seeing the effect of the hernia. I mean the shift of the stomach from the abdomen into the thoracic cavity. If the stomach is not in the abdominal cavity but next to heart, then I am dealing with a diaphragmatic hernia. So I am not able to see the hernia, but I am seeing the shift of the stomach from abdominal into the thoracic cavity, and I am saying that it is due to the diaphragmatic hernia that the stomach is not located at its normal position. Okay, next question, Dr. Ali Karega from Turkey is posting the question, is it important if there is unilateral notching in the Doppler? Should we report it? And second part of the question is 22nd weeks of pregnancy. If there is a uterine artery, RA has increased, what to do? Now, the question is that what is the importance of the unilateral notching, not bilateral, unilateral notching in the uterine artery? Today, we are having more questions of this Doppler only. Those who have joined us recently, I don't see more questions from freshers. I mean, those who have just started. So that is why we are discussing the Doppler. As we are discussing the Doppler, it means that the senior candidates, I will say, are posting these questions today more than the juniors. Now, the question from Dr. Ali Karega is that what is the importance of this unilateral notching? Now, whenever I see a notch in the right uterine artery and the gestational age is 24 and more, so it means that more than 24, if I am having a right uterine artery notching, I have to see the placenta also. Try to understand. I have to see to the placenta, whether placenta is on the right side or on the left side. And if the placenta as well as notch, I mean in the uterine artery, are on the same side, then there is a significant risk. And second part of the question is that 22nd weeks pregnant. Now see, 22nd weeks pregnancy, I will not report it as an abnormal. But after 24 weeks, if it persists, then I can make a diagnosis of an abnormal umbilical artery where I see a notching. So 22nd weeks, no, but 24 and more. So if it is crossed to 24 weeks, then it is abnormal. Dr. Nidhi, next question from Dr. Nidhi is that if first and second trimester scans are not available and patient is not sure of LMP, then how we can decide the EDD in last trimester? Now, this is the problem here. If patient is not aware of LMP, then we are completely dependent on to the ultrasound findings. But the second top-up point is that patient has not undergone any ultrasound and now she is in third trimester. What to do to calculate this EDD? That is the question posted by Dr. Nidhi. Now, in third trimester, BPD is not giving me accurate gestational age. Abdominal circumference is not very accurate for calculating the EDD. In third trimester, in late third trimester, I will be more relying on the femur length and humerus length. Femur length alone will also do. So I will be more relying on to the femur length than BPD, head circumference and abdominal circumference. So in third trimester, if the machine, now see, if the machine is calculating EDD, not if, all machines are calculating, machines are calculating the EDD and the gestational age mean from head perimetry, abdomen, as well as the femur length. But think, if it is a 34 weeks, head circumference is corresponding to 34 weeks. Abdomen is corresponding to maybe a 34, 35 weeks. But what if the femur length is much ahead? I'm talking of third trimester. What if the femur length is much ahead? It is 38 weeks. Then if I give it to machine will calculate the mean of all and it will come about a 34 weeks or maybe 34.5 weeks. But femur length is ahead. That is what I am saying. We are not relying much on the head perimetry and abdominal. We are relying more on the femur length when this type of scenario arises. So calculate your gestational age as per the femur length. If patient is not sure of LMP and no scan, first or second trimester scans are available. So don't take the mean of all. If mean of the all is also corresponding, then you have to take. But if femur length is ahead, then you are more relying on the femur length because femur length is more accurate in third trimester in these types of cases. Next question from Dr. Nidhi. Second question is that how to diagnose an abruptio placenta. In abruptio placenta, we have discussed it in placenta. We are having a course of placenta itself. In abruptio placenta, what the problem first is in abruptio placenta, that the retroplacental clot, this hemorrhage, is having sometimes, I will not say sometimes, most of times, same echogenicity as of the placenta. So that is why it gets missed. Point number one, patient is clinically fitting in abruptio. I mean, she is having pain, she is having bleeding. Take the thickness of the placenta. And if your placental thickness is more, how much is the placental thickness? Those who have completed the placenta is, they are knowing 4 centimeters. In the thickest part is 4 centimeters. Now, if all of a sudden it is not 4 centimeters, it is maybe 7, maybe 8, maybe 9, then it is the retroplacental hemorrhage, which is giving a look of a thickened placenta. So thickened placenta in inverted commas, it is not actually the thickened placenta, it is the retroplacental area which you are taking in account when you are measuring. This can be the case of the placenta abruptio. Okay, Dr. Nidhi, yeah, done. Now, Dr. Padam Sagar Chapat, Dr. Padam Sagar is posting the question, the role of the TGCs. We have discussed this thing in the practical sessions of physics and machine settings, that we are having a gain, overall gain. This overall gain will increase or decrease the gain of the overall screen. But we are having TGCs. TGCs are not like these knobs rotating, but like the sliders. So there are about 10, 12 sliders called by TGCs. Now, the question is, what is the role of TGC? Now, whenever I am having an image, this is the ultrasound image. This is the monitor. Now, with gain, with overall gain, with gain, I will be able to decrease or increase the gain of this monitor from top to bottom, from right to left. So the overall gain of the picture is being adjusted by this gain knob, which is like the round thing. Now, I am having some sliders over here. This is called as TGC. Now the question is, what is the role of these TGCs? These TGCs are like the gain also, but of a specific area on the screen. Like if I want to increase or decrease the gain of this area or this area or this area and so on. Now, if I want to increase or decrease the gain of the area number 1, I have to make this slider move towards the right or towards the left side. Then the gain of this area will decrease or increase depending on whether I am sliding this way or that way. So the point is, whenever I want to decrease or increase, I mean the adjust the gain of a specific area. Gain of a specific area, I have to move the this slider, first slider for the top and the bottommost slider for the lowermost area, and in between are these areas. Now, when to decrease or increase, that is another topic. So these TGCs are the gain of a specific area. If you don't want to decrease or increase the overall gain, here is the TGC. So TGC is nothing but the gain of a specific area. Okay. If anybody is having any more question or they want to top up or put any cross question, please post in the chat box. Okay, what was the last question? So next question from Dr. Geetanjali. What type of machine has to be taken for OBG scans? Now see, any machine, I am not here to promote any company. Any machine is good. Condition 2, you are knowing your knobs, you are knowing your physics, you are knowing your sonoanatomy, you know what to do with the machine. If you don't know what to do with the machine, then no machine is good for anybody. If you know your buttons, your physics, your sonoanatomy, then even a small machine will do wonders. So if you will ask me, user-friendly machines are G. These are user-friendly machines, and any machine from a logic series will do. Second question from Dr. Gitanjali again is, can we use PW for measuring the heart rate? Why to put PW when there is a this M mode? M mode is a dedicated mode for the fetal heart. Why to go for the pulse wave? But even if you go for a pulse wave, there is an option to take these flows. I mean these fetal hearts. But I will recommend not to go over there. Why to complicate yourself when you are having an easy option? What is SV length? What is SV length? Again, Dr. Gitanjali. SV length in G machines, sometimes they write it like gate width or SV length. SV length and gate width are they are same. When you are taking the Doppler, a line appears like this. A line appears with a small 2 parallel lines in center. Those who are doing Doppler know this. Now, sometimes the vessel is bigger. Now see, if the vessel is 10 millimeters or 10 centimeters, 10 centimeters, 10 millimeters, anything wide, then a small gate will not do. And if the vessel is only 1 millimeter or 1 centimeter, then a wide gate will not do. This gate has to be about 70% of the vessel. 70% of the vessel. Now, I have to increase it sometimes I have to decrease. For that, I am having an option which is SV length or gate width. When you will press onto this or rotate onto this, you will see that the gate width will increase or decrease. So SV length is the gate width in GE machines. Also, it is preferred if you put your question before the session, so that I will be having a list like this. I will try to take your questions also, but it is always preferred to put your questions so that it will get included in these in this list, and we will discuss these in detail. Okay, I will come to these questions in chat box later on. These questions we got half an hour or maybe 40 minutes before. So we're accepting the questions up to the last minute of the session. Now, the next question. Next question is, same Dr. Gitanjali, will post enhancements and post acoustic shadows has any effect on measurements of any pathology? No. Why acoustic shadow will tell upon the measurements? No, it will not tell. Very simple. Now, next question from again Dr. Gitanjali. There are multiple questions from Dr. Gitanjali. Will triple line end at isthmus or seam to the internal os? Now, Dr. Gitanjali, you think yourself you will get an answer. The question is, whenever I am scanning the uterus, I am seeing the triple line or any line or single line. I mean the endometrium. Is endometrium going into the cervix? No. And if endometrium is not going into the cervix, it is ending somewhere at the level of the isthmus only. So you will not see these triple line, single line endometrium, any line endometrium into the endometrium, into the cervical area. So the endometrium will be ending somewhere at the level of the isthmus. Okay. Now, Dr. Pratibha has also put a question, how to measure RI, PI, peak systolic velocity. We have already discussed that. Okay, so now see, somebody is posting in comment section, Dr. Preeti is posting, sir, sometimes I cannot see the lower end of the placenta due to the fetal head. Then what to do to rule out the placenta previa? I'm reading in the chat box. Now, in third trimester, this is the problem. In third trimester, sometimes the fetal head is towards that area where I am searching for the lower end of the this placenta. Then that is a problem. There you have to insert the probe. But if there is a fundal placenta which has been already diagnosed in second trimester, a fundal placenta will not shift into a diagnosis of a placenta previa. So you have to correlate with the previous scans, but fetal head sometimes, why? Because fetal head is having a lot of shadows. There is multiple bones, many thick bones over here, and due to these shadows, lower end of the placenta is not very easily seen. Cervical length focusing in full-term pregnancy. Dr. Swapnil is posting cervical length focusing especially in full-term pregnancy. Again, if the fetal head is there, then it is a problem. But if it is a breech fetus, then you will be easily seeing these cervical lengths, and any funneling over there will pop up. But again, if the fetal head, first of all, you have to try to get rid of that shadow which is coming from the fetal head. If you will try to scan from a different angle, most times you will get rid of this fetal head shadowing, which is coming from the fetal head. And in about 80-90% of cases, scanning from a different angle will get rid of these shadowings, and you will see clearly lower uterine segment or this cervix. But despite multiple efforts, you are not getting rid, then insert the probe. So that was the question posted in the comment section by Dr. Swapnil. Now, Dr. Soujanya is posting, should TGC be kept same for all patients? No. Now, see, you have to post a good question. These are the kiddish questions, I'm sorry to say. Why? Because if there is a button, if there is a knob, there is a function of that knob. If the TGCs has to be kept, or any knob has to be kept static for all patients, then why the company has given me the knob? The company has given me the knob. The more money you will spend on machine, more the knobs you will get over there. So no knob has to be kept static, same for all patients. We have to keep working with these knobs. From patient to patient, it will be different. I will say from organ to organ, it will be different. In a same patient, I have to slide, depending on my requirements. So never keep these TGCs or any knob. Are you keeping gain set it for 100 years? No. Same is the TGC. I told you TGC is also the gain of the specific area. So if you are not keeping your gain static for all patients, how could you think that the TGCs can be kept static for all patients? Okay. Now, Dr. Swapnil, how to report in such a case if internal os is closed or open? Sir, it becomes difficult. Yes, it becomes difficult because now the Dr. Swapnil is putting one more question in continuity of to the previous question, that if I don't see the internal os very clearly, how can I report that whether there is funneling or there is any abnormality from the internal os side? You cannot. What I told you, that you have to try to scan from a different plane so that you will get rid of this fetal head shadowing. And if you don't, I told you, if you cannot get rid, then you have to insert the probe. I mean that you have to take a TVS scan only to comment onto the internal os. Okay, so this was all. I have taken all questions and I have answered the questions from the chat box also. So see you next time. Whenever we announce these interactive sessions, you please post your questions in maybe 10-15 minutes before, can also do, so that it will be in the list. Otherwise, from chat box and from these WhatsApps, it is not always possible to go through and discuss all the questions which are haphazardly lying here. Some are posting on the mails. That is why we are accepting on the helpline number only. And we are taking these types of interactive sessions at regular intervals. So, thanks. God bless all of you. See you next time. Stay tuned. Thank you very much. God bless all of you.